mechanical ventilation ARDS. Today we're going to go through the top 10 landmark trials in mechanical ventilation for ARDS. The goal is simple. It's not about memorization. It's about pattern recognition in the ICU. So by the end, you should have a mental framework for low tidal volume, pressures, proning, fluid, sedation, ECMO, and for what not to do. ARDSNet, New England Journal of Medicine, in 2000. Before the ARDSNet, many patients with ARDS were ventilated with tidal volumes from 10 to 12 cc's per kilogram. ARDSNet randomized 861 patients to 6 cc's per kilogram versus the 12 cc's per kilogram. Trial was stopped early because of benefit. The mortality dropped from 39.8% to 31%. It's the foundation of modern ARDS care. The take-home message was ventilation can injure the lungs, low tidal volume strategy saves lives. The second trial, the Amato driving pressure analysis, New England Journal of Medicine, 2015. And the key insight there is you look at the tidal volume and the PEEP, which matters. The driving pressure, however, matters more. Even small increases in driving pressure were associated with higher mortality. The goal is generally less than 15 centimeters of water. So the delta pressure is basically the plateau pressure minus the PEEP. So you're not just ventilating volume, you're now ventilating stress. Medicine 2013, earlier proning trials in ARDS were mostly negative or inconclusive. So for years, it was just a salvage maneuver. The PROSEVA basically changed the field in severe ARDS, specifically PF ratio less than 150 on low tidal volume strategy. Early in the disease course, they were randomized to early prolonged prone positioning. Proning was done earlier, longer sessions, 16 hours per day. The results were dramatic, 16% mortality in the prone versus 33% supine. Similar large separation at 90 days. Why did it succeed while earlier trials failed? The earlier studies, patients were too mildly ill, maybe not a PF ratio of less than 150. Proning was done too late. Sessions were too short. Implementation was inconsistent. It's not a rescue trick. It's an early lung protective strategy, severe ARDS. So the FACTT trial, 2006, should we keep ARDS patients wet to support perfusion or dry to improve oxygenation? So we have over 1,000 patients randomized to conservative fluid strategy versus liberal fluid strategy. It wasn't subtle. It was real separation fluid balance. Conservative group achieved markedly lower cumulative fluid balance, several liters, improved oxygenation, better lung compliance, clinically more ventilator-free days. Importantly, no increase in shock, no increase in dialysis, no mortality difference. The key nuance that made it powerful was that the FACTT did not say fluids are bad. It just showed that once shock resolves, continued liberal fluid balance accumulation worsens lung function without improving survival. So FACTT taught us that after resuscitation, the lung becomes the limiting organ. And then at that point, the fluid restriction becomes sort of respiratory therapy, so to speak. Two trials, the number 5 is the EXPRESS, American Journal of Respiratory Critical Care Medicine, moderate higher PEEP strategy. It was not extreme recruitment. So what they did was the low plateau group, the target pressure plateau was less than 30. The EXPRESS group allowed higher PEEPs to achieve a plateau of about 30. So what that translated to in practice was PEEP was generally in the 10 to 15 centimeter range, sometimes higher, depending on the compliance. But there was no aggressive recruitment maneuver. You just push the PEEP up to improve oxygenation and allow higher plateau pressures targets. There was no mortality difference. There were increased ventilator-free days, improved oxygenation in some patients. So the EXPRESS point was that moderate PEEP escalation is safe, may improve outcomes in some ARDS phenotypes. Now, the ARD trial in 2017 was more of an aggressive recruitment, very high PEEP. That's the contrast paper here. And they received aggressive recruitment maneuvers, even up to 50 centimeters, sustained inflation strategy to open a lung. And many patients ended up with PEEP of 16 to 24. And it wasn't just about higher PEEP, it was aggressive recruitment, higher mean airway pressures. They had higher 28-day mortality. It was 55 versus 49%, and more barotrauma, more hemodynamic instability. Basically, recruitment maneuvers are not benign, and overdistension kills. Remember, extra credit ALVEOLI trial, New England Journal of Medicine 2004, was low versus moderate high PEEP, and that was the higher PEEP was basically 8 to 14. No recruitment maneuvers, there was no mortality benefit. Basically, higher PEEP alone, it wasn't a magic mortality fix. So basically, ALVEOLI first tested higher versus lower PEEP, showed no mortality benefit. EXPRESS then explored moderate PEEP escalation, targeting higher plateau pressures, and suggested possible physiologic benefit without harm. But then ARD pushed the strategy to the extreme, combining aggressive recruitment maneuvers with very high PEEP, and it led to increased mortality and more barotrauma. So across them, the key principle to learn is PEEP is beneficial in the right range, but excessive recruitment, overdistension can certainly be harmful. ACURASYS, 2010. So we're looking at moderate to severe ARDS early, within 48 hours of onset, all patients deeply sedated, and he gave them 48 hours infusion of cisatracurium or Nimbex, if you remember. The key findings were improved 90-day adjusted survival, fewer episodes of barotrauma, improved oxygenation, ventilator synchrony. It seemed to be that the sickest ARDS patients, limiting spontaneous effort may reduce VILI, ventilator-induced lung injury. And then came the corrective trial in 2019, the ROSE trial. Light sedation by then, it was standard. Better lung protective ventilation was in place. So, but now here is what we did here was early continuous paralysis plus deep sedation versus light sedation strategy with no routine paralysis. That was the difference. Those were the two arms, and there was no difference in 90-day mortality, no improvement in event-free days, and more cardiovascular events in the paralysis group. So basically, whereas the ACURASYS said we should routinely paralyze patients in ARDS, the ROSE trial came back and said that routine paralysis is not beneficial, maybe harmful actually, in patients in ARDS. And then those were those two trials, and we'll move on. One of the most important modern ARDS trials because it is as much about trial design as the physiology. Of very severe ARDS, many patients with PF ratio of less than 80 to 100. There's a high mortality risk despite maximal conventional therapy. They were randomized to early VV ECMO versus the conventional mechanical ventilation with rescue options. Key outcomes were 60-day mortality, which did not show statistically significance, but the 28% crossover from control to ECMO suggests that there actually was significance. Many patients in the control group were rescued late with ECMO anyway. So there are two competing interpretations. One is the primary endpoint was not met. It's a negative trial. But the clinical view was that the high crossover likely diluted the treatment effect. Early ECMO may still benefit the sickest subgroup. That was my takeaway. ECMO is not the first-line therapy for ARDS, but is a very legitimate rescue strategy for refractory hypoxemia, despite optimal ventilation, proning, and ventilation. Just to expand on that just a tiny bit more. So if you looked at the 60-day mortality, the ECMO group was 35%, the control group was 46%, with a p-value of 0.09, which is not statistically significant. But then when you look at the crossover, the 28%, then what happens is the hazard ratio goes 0.5 to 0.8 range in favor of ECMO. So an estimate is the hazard ratio is about 0.51. So there's a signal of benefit. Emerges when the crossover is accounted for. So EOLIA also defined death or crossover to ECMO. The endpoint showed significant benefit for early ECMO. In other words, early ECMO reduced failure of conventional therapy. So I guess the most important conceptual line is EOLIA might not be a failure of ECMO. It might be a failure of timing because control patients often got ECMO after prolonged injurious ventilation. Many were already in refractory shock, multi-organ failure by the crossover. ECMO rescue may have been too late in some. Did ECMO work if you correct for crossover? If you look strictly at intention to treat, EOLIA is neutral. But when you account for the high crossover rate, analyze treatment failure, adjusted models, there's a consistent signal suggesting ECMO may reduce mortality in the sickest ARDS patients. This is the ARDS. We're talking about the Berlin definition in 2012, standardized ARDS into mild, moderate, severe. So mild would be a PF ratio of 200 to 300. Moderate is 100 to 200. Severe, less than 100. It also required acute onset within a week, bilateral infiltrates not explained by cardiac failure. It allowed ARDS trials like the ones we discussed, PROSEVA, ROSE, EOLIA, to become comparable. A recent consensus work was done, updated in the ATS in 2024. First of all, management updates in ARDS, but also a global strategy for ARDS. So it's no longer only an intubated diagnosis. We now recognize ARDS in high-flow nasal cannula, non-intubated hypoxemic respiratory failure, using SAT/FiO2 ratios as surrogate markers. ARDS often begins before the ventilator, not after it. And there is the other issues, there's a strong emphasis on early lung protective strategy across all oxygen support, low tidal volume, plateau pressure less than 30, higher PEEP, moderate, severe ARDS, proning, and ECMO. It's more of a spectrum as opposed to one single disease. There is pulmonary versus extrapulmonary ARDS, variable recruitability, different responses to PEEP and paralysis. So the Berlin definition gave us a shared language of ARDS severity. Modern critical care expanded that framework. So now we look at non-intubated patients. We're looking at the ROX index, the SpO2 over FiO2. And that's basically in a nutshell. So overall, we looked at the ARDSNet, low tidal volume, AMATO, we looked at PROSEVA, FACTT, EXPRESS, ART, ACURASYS in the ROSE and EOLIA, as well as the Berlin definition and the ATS updates, and basically the core ventilation principles: tidal volume 6 to 8, plateau less than 30, driving pressure less than 15, prone. If the PF ratio is less than 150, remember ECMO for refractory hypoxemia, and remember early versus late. Remember how the crossover benefited the patients, but it would be better if you thought about it early, and so you don't scramble last minute.